Today we're going to talk about the neuropsychiatric aspects of traumatic brain injury with hopes that I can highlight that this is a very challenging clinical population with distinct diagnostic and assessment dilemmas. At the end of this talk, we're hoping that everyone can describe common neuropsychiatric disturbances after TBI, review clinical and demographic risk factors, and recognize psychosocial and pharmacologic interventions that we often use to treat patients with these symptoms. I'll touch briefly on the epidemiology, and then we'll talk about some of the cohort studies we've done here at Hopkins to better conceptualize understanding these patients. We'll pivot over to talking about management, and then we'll wrap up talking about where this field is headed in the future directions of TBI and psychiatry. So first we have to start off talking about why is it important? What is TBI, and what did we know about TBI? What's been studied so far? The best place to start is always with the definition. What is a traumatic brain injury? So there are various classification systems, the ACRM, VA-DOD, the CDC, various classification systems that have different definitions of criteria that actually consider a diagnosis of TBI. But the most important point is that TBI is a clinical diagnosis. There is a presence of symptomatology that has to be there in order for it to be considered a TBI. It could be one of three of the following. The first is loss of consciousness. This is where we ask the patient, did you black out? Second is loss of memory. Do you remember things before or after the accident? Third is altered mental state, where you dazed, disoriented, confused, as you heard today that happened after a car accident. So you have to have at least one of these three symptoms in order to be considered a TBI. Even though there's no standardized definition, most people kind of rely on this. It has to have some traumatically induced physiologic disruption of the brain, which means it's coming from the outside. There has to be some trauma to the skull that happens causing these symptoms to occur. Now, you may or may not have focal neurological deficits, and your head imaging may or may not be normal. But again, a head injury is not always a brain injury, so the presence of these symptoms is really important, as we'll talk a lot about today. TBI is a big public health problem, huge. About 3.6 million TBIs occur in the US annually, and about 3.2 to 5.3 million people suffer with some TBI-related disability. It's also a very expensive disease. If you're looking at people who are discharged from the ICUs, people who are discharged from the ER with concussions, people who are going to rehabs, we're looking at anywhere from $60 to $221 million in direct and indirect costs. And as we'll explore today, at least 43% of patients have some kind of functional or neuropsychiatric sequelae that happen afterwards. It's important to understand the mechanism of injury. So when a patient comes to you with a TBI, important to ask how they got that TBI. So with a growing geriatric population, we're seeing a lot of people who are suffering from falls. So falls is typically usually what we see coming into the ER. This is followed by motor vehicle accidents and assaults, particularly here in Baltimore, very commonly a reason that we see people coming in with injuries. This group of, quote, other, are people who are kind of now getting more media attention, people who are getting repeat concussions due to sports-related injuries or blast injuries due to being in active combat. Why do we as psychiatrists need to know about TBI? Why is it important in the psychiatric community to understand this? Well, the answer to that is threefold. The first is there are distinct neuropsychiatric phenomena that we see that you don't normally see in idiopathic psychiatric disorders like major depression or bipolar disorder. And because it's distinct neuropsychiatric phenomena, many of these patients are refractory to treatment. So you may not see a patient respond to an SSRI like they normally would with major depression as they would if they had depression after TBI. And finally, as we'll talk about, there is a distinct nuance of emotional and behavioral discontrol that is present in these patients that may or may not be comorbid with the mood disorder, but makes treatment even more challenging when we see these patients. If we think about the TBI like this devastating occurrence that occurs with the patient, and the patient may or may not have had some kind of neuropsychiatric problems before, compounded together, it creates a significant amount of disability. We see problems with social integration, workforce participation, we see issues with occupational activities, and overall ADLs and functioning. If you think about neuropsychiatric disturbances after TBI, you can kind of put them into four big buckets. There's the emotional piece, there's the cognitive piece, There's the behavioral piece, but you also don't want to ignore physical problems, because if someone got hit in the head, very likely their body was injured as well. But the most important thing to remember is how well a patient does after a TBI depends on what happened before the injury, at the time of the injury, and after the injury. A lot of cohort studies and researchers in the field have tried to conceptualize this connection between psychiatric disorders and traumatic brain injury. But the problem is a lot of this is using a syndrome-focused approach. So this is a study that was done last year by Howlett et al. In 2022, looking at overall Axis 1 diagnoses and TBI and the trajectories over the past 5 years. The top line is sort of all Axis 1 diagnoses, and then they break it down into mood disorders, substance use, anxiety, etc. You can see the blue line is mood disorders, and more commonly, this is what we see often in TBI. Mood disorders are the most prevalent after TBI. And over time, as you see with this trajectory, things get better. So compared to 1 year, at 5 years, symptoms have pretty much, or the syndromes have gotten better. But this is not what we're seeing in clinic. And today was a perfect example of that. Even several years after an injury, we have patients saying, I'm not getting better, I'm actually getting worse. So what does that mean? That leads us to the question of, is there a nosologic issue going on? Is it not that we should be looking at syndromes, but rather we should be looking at symptoms? So the first is that there's a distinct phenomena of discontrol that we see in these patients. And when you look at discontrol, we can kind of break them down into 3 pieces. The first being emotional. So affective instability, moment-to-moment shifts in mood, and sort of being happy 1 minute, angry the next minute. Pathological laughter and crying. This is where we see uncontrollable periods of laughter or crying in response to trivial stimuli. An example of this is a patient of mine who started crying after she watched a gum commercial. Or irritability, being on edge, short and quick to anger. Behavioral problems are also something you want to think about. So aggression or agitation we often see. Sometimes patients can be disinhibited, blurting things out at the family table, or becoming sexually inappropriate. And then there's that third piece of cognition, where we're often seeing patients struggling with slow processing speed, with verbal learning issues, difficulty initiating and completing tasks. So combined together, this is sort of this phenomena of discontrol that we really want to be thinking about when we're formulating these patients. So this kind of prompted us to ask the question, how can we study these patients better, and what can we do to identify neuropsychiatric correlates? So I'll talk now about some of the earlier studies we did. These are some of the studies we did when I was starting off in my career with my wonderful mentor, Dr. Rao. And we asked the question, could we look at these non-traditional symptom scales of these nuanced symptoms in TBI and see if there is any correlation with mood disorders? So what we did was we looked at overt aggression, pathological laughter and crying, social functioning, and then we looked at whether or not there was a correlation to scores on specific mood and anxiety scales. So this is a group of patients that were first-time TBI, so no prior history of TBI, that were admitted to the rehab units either at JHH or Kernan. And we lost about 39 to follow up, and we ended up analyzing about 103 participants. So the first point is that the timeline was as such. They had to have blunt head trauma, so no penetrating injuries, no skull fractures. And they were admitted to the rehab, so these are more chronic patients. And we were basically doing these instruments at 3, 6, and 12 months. And what we found when we looked at sort of clinical variables is that the most common gender or sex was 62.1 was male. So majority of these patients were male that suffered the TBI. The second was that the most common form of injury were motor vehicle accidents. And the third is that the most common severity of TBI was mild TBI. Now, when we looked at new onset depression, so these are patients who had no prior psychiatric history before, but developed depressive symptoms after the TBI, we found that there were higher prevalences of new onset depression in the first 3 months after injury. But interestingly, the presence of poor social functioning early on predicted the development of new onset depression even 12 months out. We also then looked at different types of aggression. So the overt aggression scale looks at verbal aggression, physical aggression to self, others, and objects. What we found is that the most common type of aggression was verbal. But interestingly, if there was decreased social functioning early on and the presence of new onset depression early on, this was actually associated with verbal aggression later on at 12 months. We looked at pathological laughter and crying using the pathological laughter and crying scale. This is very highly validated in the stroke population, and we also use it quite often in TBI. When you parse out each symptom, we found out across the board at each time point, pathological laughter was much more common. And the folks that were experiencing the most symptoms of pathological laughter and crying were those with mild TBI. Then if you look at across time points, the pathological laughter and crying, and you compare those that had it, we call it plaque, those who had plaque versus those that didn't. Those that ended up having plaque across time points had higher scores on the HAM-D as well as the clinical anxiety scale. So this association with plaque and mood disorders was quite evident in this particular cohort. So what did we learn from this Kernan study? Firstly, males were injured more than females. Early mood symptoms were associated with aggression later on. Mood symptoms were also correlated or coexisting with pathological laughter and crying. And the most common type of TBI severity was mild TBI. So what's so important about mild TBI? You heard a little bit about it today. And why is it so important to me in terms of my career and my trajectory? I've spent the last several years of my career really focusing on this patient population for several reasons. The first is, this is the most common severity of TBI, about 70 to 90%. You've already seen from our study and in the literature, very commonly, if a patient has TBI, it's likely going to be mild. These symptoms are often overlooked by doctors all the time. Patients are discharged from the ER and told to walk it off, you'll get better, and really they're dismissed. And as a result, they're very difficult to treat, and their symptoms end up being very refractory. There's also a variance in severity and persistence of symptoms. So some patients get better, but many of them persist years later. And while you have that 7 to 10 day window of post-concussive symptoms that really should get better, still 33% remain with some kind of functional impairment years later. And my clinic is chock full of these kinds of patients years later. So we wanted to understand this a little bit more. So this is a much larger study that was done between the years of 2014 and 2016 out of both Hopkins ER, so the downtown ER as well as Bayview. And the idea was that this is a head injury seromarkers in response to trauma study, initially kind of identified as a study looking at biomarkers of head injury. But we screened about 4,450 patients, and at the end of the day ended up enrolling 500. And when we used the VA-DOD criteria, one of the other classification systems, and applied it to this cohort, as we expected, majority of them had mild TBI. 407 out of 500 had mild TBI. So going back to the definition of TBI, remember, loss of consciousness, altered mental status, post-traumatic amnesia, very important. What makes something considered mild is the duration of those symptoms. So less than 24 hours of PTA and AMS, it falls under the category of mild TBI, and less than 30 minutes of LOC, mild TBI. Now you can have normal imaging findings, or you can have a Glasgow Coma scale of anywhere from 13 to 15, which is the normal. 15 is a normal scale number. So timeline, a little bit more chronic than the earlier study I presented. So this is within a 6-month span. So patients come into the ER, blunt head trauma. They're recruited within 24 hours, and we followed them at 1, 3, and 6 months. While the focus of the study was on biomarkers mostly, I'm going to focus what I was interested on, which is the post-concussive phenomena, as well as the psychiatric symptoms and functional outcomes. So we did 3 scales. The River-Mead, which is a post-concussive scale that captures neurologic and psychiatric symptomatology. The PHQ-9, which you're all familiar with, high sensitivity and specificity for detecting depressive symptoms and severity. And then we looked at the GOES. This is called the Glasgow Outcome Scale Extended. This is basically a scale that looks at functional recovery, going on a continuum of 0, dead, to 8, full functional recovery. We used this as a dichotomous variable and cut it off at 7 and said anyone less than 7 was incompletely recovered, anyone at 8 was fully recovered. So what did we find? We took the cohort and we divided them into subgroups and group membership based on severity of symptoms at the outset. So those that had higher River-Mead scores, aka higher PCS or post-concussive symptoms, right at the outset are the ones that got worse later on. Those that had mild or minimal post-concussive symptoms at the outset got better later on. Then we asked about predictive markers. Well, we know that LOC, AMS are very important in the diagnosis of TBI, and particularly mild TBI. What do those clinical variables tell us about who's going to get better as the year progresses? So we took all the participants that had mild TBI, And we divided them into 4 distinct groups based on the presence of loss of consciousness and altered mental state. So there was a group that had both LOC and AMS, those that had just had LOC, those that just had AMS, and those that had neither. And what we found, just as we would expect, is that the presence of loss of consciousness and altered mental status at the time of injury resulted in those that had the highest rates of depressive symptoms and post-concussive symptoms, which is pretty predictable at the 6-month mark. But these were also the people that were at the highest risk of incomplete functional recovery. So what did HeadSmart tell us? Those with severe PCS early on do worse later. Those with mild or minimal PCS early on get better later. Presence of both loss of consciousness and altered mental status at the beginning of the time of injury means that there are going to be worse outcomes later. So now we'll pivot over to talking briefly about management and how we manage and assess these patients. Because again, it is psychiatry, it's just a little bit with, there's some nuances that we look at. So as with all psychiatric evaluations, we want to be very complete and comprehensive. You want to do a full FIPS history. What's important with step 1, though, is it's important to ask the family members, what was this person like before their injury? What was their personality like? What was their functioning like? How were they able to interact with people prior to the injury? What are they like now? Are they able to balance a checkbook? Can they make a grilled cheese sandwich? These are things you really want to be asking. Then you want to do a brief neurological exam. All my fellows and residents here are aware that I asked them to bring a tuning fork, a reflex hammer, the Snellen chart into the clinic, because detecting neurological deficits, even if it's 6 years out from the injury, might explain some of the phenomena and presentation that we're seeing now. Important to look at the problem-solving, problem-focused workups, because we really want to figure out what's going on if it's not just psychiatric. So if a patient's coming in with sleep disturbance, very common after TBI to have obstructive sleep apnea, not central, you want to do a full sleep study, and you want to make sure that you're not missing this as part of the issue before you start prescribing medications. You want to do ancillary studies to help establish the diagnosis. So psychosis after TBI, very rare, but true story. A patient came in having psychotic symptoms that weren't getting better after antipsychotic use. Come to find out, an EEG was never done, and they were having post-traumatic seizures. So these psychotic episodes were happening in an interictal pattern. Multi-pronged formulation, really important. It's very easy to chalk up people that have a TBI to saying, this is a brain disease, that's what's going on. But we want to take a step back and use the perspectives model to really apply it to the patient and look at it from a holistic framework. Multidisciplinary treatment is really important. TBI does not exist in a bubble. It's not just psychiatry, but it's all other specialties, and it's important to connect and coordinate and collaborate care. And finally, consultations and referrals are really important. So I'll do a workup, for example, I'll order a pituitary panel because pituitary hormones are often disrupted after TBI. If something comes back abnormally, I'll refer out and send people to neuroendocrine or neuropsychology for cognitive testing. It is really important to apply the perspective model to these patients. Like I said before, it's easy for clinicians to chalk up patients with TBI as they have a brain disease. But if we take a step back and go back to the concept of what they have, who they are, what they do, and what they've encountered, it's really, really helpful for us to characterize and deliver treatment that's specific to that patient. So yeah, they have a brain injury, they've got neuronal injury, which has resulted in neuroanatomical and neurophysiologic changes. But what about their premorbid vulnerabilities? If their personality vulnerabilities sort of lended them to dealing with this particular incident in a different way, that's important for us to know. This can sometimes be explained by patients over-exaggerating or minimizing their symptoms. What about what they do? We've talked about impulsivity and disinhibition. This can really lead to a lot of problems in the home. Substance use, domestic violence can often be things that we're thinking about. Or the lack of behavior, amotivation and apathy, not doing things, can really impair patients in getting to their doctors and actually engaging in treatment. And finally, demoralization is something we're seeing all the time. These are patients that are really struggling with, I don't know who I am anymore after my brain injury. And that's where we are sort of tasked with the duty of basically rescripting and working with them to kind of rewrite the narrative. As a TBI neuropsychiatrist, I would say I spend majority of my time coordinating, collaborating care with other physicians and in other specialties. If it's PM&R, neuropsychology, neurology, audiology, you name it, pain management. It is truly a multidisciplinary intervention. But even within psychiatry, there are different modes that we can use. Anger management, mindfulness, occupational therapy, social skills groups that we have, psychoeducation. So not only is it interdisciplinary or multidisciplinary, it's also multimodal within psychiatry. When we look at pharmacologic interventions that we use to treat these patients, there are actually not a lot of treatment trials that have been done, unfortunately. One of our former fellows, Barry Nair-Peretti, and myself wrote a very large systematic review looking at pharmacologic interventions to treat depression after TBI, and really there are not that many studies out there, but across the board, typically SSRIs are the first line. Sertraline and citalopram have the most evidence. Methylphenidate in one trial and in monotherapy was found to be very beneficial. For PTSD, a lot of veterans have been studied, and sertraline has been found to be efficacious. If we're looking at apathy, inattention, executive function problems, oftentimes the go-to are stimulants, or if they don't have a seizure disorder, amantadine. There's robust evidence for these two agents in severe TBI specifically. Memory deficits are actually being studied in larger trials now, but really cholinesterase inhibitors, especially donepezil, can be very effective. It is takes a little adjusting to when you have to prescribe donepezil to an 18-year-old who has, cognitive deficits after concussions from sports, but it does happen and they are effective. Lots of times on the consult service, on the inpatient services, we are getting called on agitation, very commonly, particularly with severe TBI. And we have a curriculum actually on how to manage agitation in these patients that we're developing, because we're finding that non-psychiatrists really struggle with this as well. But for the most part, mood stabilizers have a lot of efficacy. So valproic acid at doses of 1200 and 1250 and above, or oxcarbazepine in doses around 1200 are very useful to manage acute agitation. You also want to rule out that this is not a post-concussive or post-traumatic confusional state or a delirium. And then if this is more of a chronic thing, you can use mood stabilizers. Post-concussive symptoms really don't have a treatment at this juncture. Lots of times what's happening is people are targeting specific neurological symptoms, so headaches with gabapentin or neuropathic pain, as well as tricyclic antidepressants. And finally, insomnia, a really difficult to treat symptom after TBI. You want to start off with doing a full workup, doing the full sleep study. CBTI for insomnia is very helpful before jumping to other agents that you would use pharmacologically. But Ramelteon and Trazodone have been found to be very helpful in these particular patients. Other interventions, obviously psychotherapy. So as mentioned before, I'm often encountering situations where patients are like, I'm not the same person that I was before. So I do come from the approach of, we may not be able to get you back to who you were before, how you were before the injury, but we certainly can get you better than you are now. And kind of giving them that hope that they can get better than what they're presenting with today. We also want to rescript the narrative and help guide them in that aspect. Of all of the studies that have been done in specific types of psychotherapy modalities, cognitive behavioral therapy has been the most efficacious. One thing with CBT is you have to be very mindful that you want to deliver a modified CBT to these patients, because there is that cognitive sort of deficit piece that you want to be thinking about. Cognitive rehabilitation is also very helpful. So this is where I tell patients, I'm going to be sending you to the brain gym. This is where neuropsychology will give patients specific exercises and tools to kind of help them remember things and help them understand more, how to keep track of their lives and organize themselves. And then, of course, we do substance use counseling, supportive therapy, behavioral activation therapy. There are some supplements that are kind of up and coming now that are looking at managing post-concussive symptoms. Nothing's really been groundbreaking so far, but people are looking at various sort of off-label supplemental use for post-concussive symptoms. PM&R does a lot of physical things to help with brain fog, like aerobic exercise. There's a lot of aspects of vestibular therapy that help patients that have the post-concussive phenomena that continue. And then we also think about sort of physical therapy, getting their bodies rehabilitated from a physical standpoint and physical perspective. So where are we headed with this particular field, and what's the future of TBI? So the first is we really need integrated care sites. So patients come and see me for pharmacologic management, then they're going across the hall to see the therapist, but then they're going downtown to see the neurologist and the audiology and pain management, and it's very fragmented. So having a one-stop shop where patients can really be seen by all providers is really, really beneficial. The second piece is the psychosocial rehab programs. Most clinics have PRPs, but our patients oftentimes can't tolerate groups. They're often blurting things out and becoming disruptive, and they get kicked out of PRP, which is really not helpful for them. This was the impetus for us to raise and create the HOPES program that Dr. Rao started, which is really targeted just for patients with brain injury to help them regulate within groups. Early screening is really important. So now that we've seen that LOC, AMS is a high predictor for poor outcomes, prior history of psychiatric illness or high risk for depressive symptoms early, you want to catch this. Personally, I'm interested in neuroimaging screening, so my current NARSAT award is looking at patients that are coming out of the ER with first-time mild TBI and looking at functional neuroimaging changes. Are there resting state fMRI changes that happen in the acute period that might predict depressive symptoms later on? So early screening with novel neuroimaging interventions is also really helpful. Early interventions is key. Could we talk to our ER colleagues and say, hey, this guy has a concussive episode, he might be someone that's going to do worse. Could we give them resources on his way out of the ER or her way out of the ER? Neurostimulation, RTMS and TDCS, we actually did a study at Hopkins a few years back, but generally the effect sizes are it's a mixed bag. Part of the problem might be because neurostimulation is being delivered to the frontal areas in a non-specific manner. So the dorsolateral prefrontal cortex is huge. So targeting specific areas, particularly with neuronavigation and fMRI-guided neuronavigation, might be helpful in making more efficacious interventions with neurostimulation. And finally, treatment trials. For those who are not doing well with pharmacologic agents like traditional SSRIs, what does ketamine look like in these patients? What does vortioxetine look like? And these are conversations that we're having right now sort of with other institutions as well. So in summary, the presentation of traumatic brain injury doesn't always fit the DSM model and these check boxes that we typically see. There's a unique phenomena of symptoms that's often surrounded by this idea of discontrol, emotional and behavioral. There's nothing mild about a mild TBI, which you heard today firsthand. And there's a lot of things that are involved in multidisciplinary management of these patients, both amongst other specialties, and multimodal within psychiatry. And there's a lot that we have to learn, a long way we have to go to understand pathophysiology and connections to psychiatry within TBI. I'd like to take this moment to acknowledge my mentors and all of my colleagues. Drs. Lacustos, Bechtel, and Rao have been integral in my career in TBI psychiatry. I'd also like to thank my colleagues who have done a lot of the research that I presented today with, and my other mentors, Dr. Smith and Dr. Chisholm, who have also been integral in my career development. And I'll leave you with this final point, which is the next time you interview a patient with TBI, always remember that there is a complicated battery of symptoms that often revolve around emotional discontrol and behavioral discontrol. And the more often we're doing this as clinicians, we're better able to ask research questions, better able to find treatments, and do better for our patients. And with that, I thank you.
Hello. Oh, there we go. Now I'm on. That was a great talk. Wow, great content and magnificent delivery. Let me start with a question for you, Dr. Roy. The emotional lability piece. Can you talk about the targeting treatment for that particular piece of the equation? How do you treat emotional lability?
Yeah, so that's been explored somewhat in some treatment trials. Early on, a lot of the SSRIs, particularly sertraline and citalopram, had been used to kind of treat sort of the fluctuations in mood. But there is a lot of evidence now that mood stabilizers, particularly valproic acid and even lamotrigine, might help with that in terms of a treatment standpoint. Also frustration tolerance, from therapy, learning about when to figure out where your battery is and where your gauge is from a behavioral standpoint.
Great. Thanks. Dr. Tobolowsky.
Yeah. Do we have any information about TBI location and severity of symptoms and symptom onset with regards to where the TBI occurred?
Yeah. So.
You want to repeat the question?
Oh,
sure.
For
our Zoom audience.
Oh, sorry. Yes, sorry. So the question is about, do we have any information about the location of the TBI and how that affects treatment, particularly, and the symptoms that come about. So we didn't have too much time for me to go into the neuroanatomy, which is one of my favorite parts about this topic. So if you think about the brain, which is this jelly-like substance in this hard encasement called the skull, no matter where the injury happens, because of these frontotemporal bony prominences, there's this shearing that can happen. So the most vulnerable areas of the brain are the frontotemporal areas. In particular, the orbitofrontal cortex is responsible for sort of that break the go, no go. So that's where we see a lot of this kind of disinhibition, impulsivity, and agitation. The ventromedial prefrontal cortex, that's typically where we see problems with apathy. And then the dorsolateral prefrontal cortex is really where we have problems with executive function. I don't know if that answers the question. So really the frontotemporal areas is where it's important. Now, if you see someone that has a brain bleed in any of those areas, you can kind of expect those symptoms to develop.
Thanks. Dr. Gilbert.
Yeah, so the two scales that were used was the social functioning exam. This is where patients are, the patient's perception of how they are functioning. So this is where they think they are not doing well in their job, not doing well in school. They think they're a poor spouse. And the second was the social ties checklist, the connection. Are you eating lunch with someone once a week? Do you have a pet? Do you see your family members for at least an hour a week? So the social functioning from our studies really was encompassing a patient's perception of their functioning as well as social connectedness.
Great. Thanks. Other questions? Yes, Dr. Coglin.
Thank you. So the question was about in my current NARSAD study, and were we collecting data about prior TBI? So the whole focus of this study that we're doing out of the ER is to look at to consider TBI as a mechanism of disease. So we're only enrolling people who had no prior history of TBI. So this is first time mild TBI, and then we're looking at functional neuroimaging. But it's a great point to look at repetitive concussions as well, because that's obviously it's a cumulative effect. But our study only looks just at first time. Thanks,
Good
Jen.
point. Good point. Dr. Margolis.
Yes, thank you. Very excellent talk.
Thank you.
What would you recommend for those of us, typical clinical encounter, any number of types of clinics? An adult says, yeah, 30 years ago when I was a kid, I was playing sports, and they said maybe I had a concussion, or I was in an accident and I had a headache for a while afterwards. And that's a very common thing to hear. When and how should we take that into consideration in addressing something you might have maybe sort of mood disorder, schizophrenia, or anxiety disorder?
So the question is about if someone had a remote, many years ago, history of TBI, how do we sort of take that into consideration when thinking about other disorders? So I think that just goes back to taking the FIPS and looking at the chronology. So you run the risk of patients kind of attributing their symptoms maybe to a TBI, which might happen. But that's where I really like to pinpoint the collateral, because if a family member can tell you what they were like right after that injury, and if it was really a negligent thing that happened, it was just a negligible experience and it was just, a brief tap on the head or something like that, then you know that it's likely not playing a role now. But I usually like to get the chronology much more specified. And what I do is I get the details of that injury and exactly what happened. Because typically if it was really that much of a devastating event, you will hear a lot about it when they're talking about that particular thing. But if they're kind of bringing it up sort of in hindsight, the importance might not be as much, have as much weight, I think.
Other questions? Yes, go ahead. Dr.
Thank you.
Question about cerebellum. 2 points. One, is it looked into as a way of a predictor, getting maybe worse, or how they do it, if ever any injury to the cerebellum? And second, maybe even more intriguing, a potential role of cerebellum targeting in aging for rehabilitation. You know, it has to do with the emotional factor, connection to the brain, including cognitive or other possibilities. So just kind of bigger picture, you know. I'm quite intrigued in that area, and we've heard a lot about that, and maybe something later as well.
Absolutely. So the question is about the role of the cerebellum and how much importance we put into that in formulating. So the cerebellum is actually a very, very important, especially in neuropsychiatry. We're talking a lot about it now, especially because of the projections to the frontal areas of the brain, and its responsibility for attention and coordination and motor function is really important. A lot of the times with the imaging that we get of our patients, much of the focus is really on the cortical structures and subcortical structures, and we're kind of looking at that. But I think this points back to the idea of when we do our brief neurological exam and getting a history, if we know that there was some cerebellar dysfunction there early on, that may also be contributing to the mood lability and a lot of the instability that we see with affect that's happening. And so... but I think also when we send our patients over to PM&R, they're able to do a lot of the cervical vestibular interventions that can sort of address some of these symptoms as well.
Great, thanks. Other folks? Let me ask you another question, Durga. You mentioned a study looking at serum markers.
Yeah.
I presume we would have heard that there have been positive findings in something like that. Are there any physical tests that can tell us much about whether a person's had a serious TBI?
The issue is that a lot of the serum markers, that, like for example, BDNF was one of the big ones that was looked at. They're very non-specifics for the CNS. So in terms of that particular study, nothing really would pan out because you have to target it specifically to areas. Now there are specific proteins when we are talking about, for example, CTE, like TDP43 and other types of proteins that we might be wanting to look at for long-term outcomes. But I think right now we're just continuing to explore other peripheral markers.
And I guess mild TBI, I think you said, is defined as in part by the absence of imaging findings. Right?
Typically imaging findings are normal. Now there is a subset that do have brain bleeds that can be considered complicated mild TBI, and that's a whole other discussion. But generally speaking, most classification systems consider the structural imaging to be normal. Structural imaging.
So I guess in general, mild TBI is like all of our psychiatric illnesses in that the diagnosis is entirely syndromic.
Clinical.
There's no physical basis for diagnosis.
It's a clinical diagnosis based on symptoms. Yeah.
Right. Anyone else? Okay. With that, I will thank you for a really wonderful grand rounds. Thanks.
Thank you. Thank you.